That sounds great. So my name is Courtney Slette. I am a pediatric speech language pathologist, and I've been specializing in pediatric feeding and swallowing disorders for the past 6 years. So this is an area that I'm very passionate about. It was hard to condense everything I want to say about feeding and autism and all of the nuances that go into feeding kids with autism into a 30-minute presentation, but we're going to do our best to get the key points across. We'll probably but go a little bit quicker through the definition part, different disorders, diagnoses, and then we'll hopefully have a little bit more time to focus on the intervention piece and what therapy looks like. Okay. So our learning objectives today is to figure out the diagnostic criteria, review those a little bit, and then identify differences between picky eaters and problem feeders, what makes a child with autism nutritionally vulnerable, strategies for families, and then appropriate referrals. A little bit of who's on your feeding team, both within St. Luke's and outside of St. Luke's. You're mostly going to be looking at speech language pathologists and occupational therapists. I would say historically, speech language pathologists get more training in the dysphagia, the true oral motor part of feeding, and then occupational therapists traditionally get more of that sensory background. I would say, though, that any of us who are specializing in pediatric feeding and swallowing will have a lot of cross-training in both because you cannot separate the two of these. They go hand in hand in a lot of different ways that we'll talk about later on. Settings you might find us in, so different points of care for kids with autism and feeding difficulties are going to be in the inpatient or acute side, home care, and outpatient. I currently split my time between acute care and then pediatric outpatient feeding therapy. And then I've done community clinics as well. So I feel like I have a little bit more awareness than those who have just kind of lived inside the St. Luke's system for therapies to bring to the table when talking about different therapies for kids. This is a visual that I really like to share because I think it's a good representation of pediatric feeding disorders and the different types of things and challenges we're going to encounter for our children with autism who have feeding difficulties and for our kids without autism who have feeding difficulties. So just like autism is a spectrum, it's a spectrum of feeding difficulties. Some of our kids are going to need a nasogastric tube or a G tube to support their nutrition. Some kids are going to cry at the presentation of a new food. Some are maybe a little bit stressed at the meal times, but maybe not completely. And so there's just a really big variety of what feeding challenges can look like for kids with autism and for kids who have feeding difficulties. So this is just a great representation of that. So types of pediatric feeding disorders. The DSM has identified a few different that we see fairly often for children with autism. So one of those is going to be our pediatric feeding disorder. This one I tend to find as kind of our best catch-all. Then we go into avoidant restrictive food intake disorder, otherwise known as ARFID, rumination disorder, and PICA. For our children with autism, and why this is such an important topic, is the research shows that between 30 and 84% of children with autism are going to experience some degree of feeding challenges. Again, it's going to vary on the severity, but it's very, very prominent in this population. And so it's important that we are all knowledgeable and can help kids get access to the care and help their families, because really that's a big part of this too, is we're treating families and children. And so that's why this matters. So let's go ahead and dive into each of those disorders. Pediatric feeding disorders, Feeding Matters. I've attached a link, which I don't know if you guys will have access to, but this is a great resource to go to their website on Feeding Matters. Talks a lot about pediatric feeding disorder and a lot of other things, but it's described as impaired oral intake that is not age appropriate and is associated with medical, nutritional, feeding skill, and or psychosocial dysfunction. And then Lindsay, if you'll go to the next slide, we can break those down. So pediatric feeding disorder has been a really helpful tool for us as feeding therapists to use in our diagnostic codes, because oftentimes oral aversion, we get some pushback for that code. And so a lot of our kids who are having that oral aversion criteria are going to meet at least one, if not all of these areas for pediatric feeding disorder. So it's been really helpful for us to help advocate and reduce the risk of getting pushback from insurance. So for pediatric feeding feeding disorder, we're looking at medical. That is going to be gastrointestinal. A lot of times we're going to see constipation, aspiration potentially, respiratory compromise. Then we're going to have nutrition, so vitamin deficiencies, malnutrition, difficulties with hydration. Feeding skill, this is a big one for us when we're looking at, is going to be our need for texture modifications, and then use of modified feeding positions or equipment that might fall into that. This is also going to be where we see maybe our oral motor challenges or oral phase dysphagia is often the code we'll use for that. And then psychosocial. This I feel like is the piece that's often overlooked, but is the most impactful for a lot of families. It might be on the child who's having aversive behaviors to the feeding experiences. And more importantly, I would say it's the disruption between caregiver-child relationships. Feeding your children is one of our most intrinsic and innate drives. And when that is hard, it affects the whole family and it affects them really deeply when that experience is challenging. And so this is an area that we really look at too when we're looking at our parent interviews and gaining information about the feeding disorder.
Cortney, I think we have 2 questions before we go on, if that's okay. So one from Megan. What is the ICD-10 code for the feeding disorder?
It looks like Dr. Francis just covered that. Yep.
Thank you.
And you will see chronic and acute. It does differentiate between the two. I would say most of our kids with autism are probably going to qualify under the chronic versus the acute care or the acute, unless it's a very new sudden onset hospitalization for weight loss, something like that, a drastic change, then you might more appropriately use that acute for the referral.
Amy, did you have any follow-up?
Oh, nope, sorry. That was a mistake. I need to take it down. Thanks.
Right. So then we have avoidant restrictive food intake disorder. I feel like this diagnosis has been popping up a little bit more frequently for us. Most of the time, I'd say it's being appropriately used. I think this is also one where we're seeing it more often because we're finally getting a description for what these kids are experiencing. ARFID requires a very particular type of treatment. Sometimes the best fit is occupational therapy and speech therapy. Sometimes the better fit is going to be counseling. It really depends on what's driving the child. And so we might try therapy, and there's some kids where therapy is going to make it worse. And then there's times where it's going to be helpful. And when it is truly ARFID, this is when we're having therapists who are trained in ARFID, and how it looks different than your typical sensory integration food play is really important and imperative for getting these kids moving in the right direction. So for ARFID, we are looking at a few different criteria. That's going to be failure to achieve expected growth standards for children, nutritional deficiencies, dependence on enteral or oral nutrition, and then marked interference with psychosocial functioning. So for children with ARFID, it's co-occurring. The research is showing anywhere between 12 and 33% for kids with autism. I would say of my caseload, I have 6 currently with ARFID, 5 of them have an autism diagnosis. So fairly common. Otherwise, I would see anxiety. Our kids with high anxiety are more at risk for ARFID as well. And that's just kind of what I've seen clinically coming across. This image, again, I think is a great representation of what encompasses ARFID. At the surface, you're going to see food aversions, avoidance, limited variety, but there is a lot more that goes into it, and that drives these feeding patterns. It might be neurodivergence. It might be fear of foods, trauma, history of allergies. There's a lot of different things that are going to play into what we're seeing at a surface level. Then we have rumination disorder, and this is going to be repeated regurgitation of food for a period of at least 1 month. So with rumination disorder, I would say see this more on the acute side, not quite as often in the outpatient setting. And really our biggest intervention in this is going to be that diaphragmatic breathing. So depending, we'll see a shorter care period of time for rumination disorder, not typically long if that's all that's occurring. And then we have PICA, so persistently and compulsively eating non-food, non-nutritive substances. Often, at least in the places I have worked, this is more addressed by occupational therapy, so that we're working on identifying, are there oral seeking behaviors? Are there other things potentially contributing to or compulsively eating? So again, kind of a collaborative approach, but these are two that we'll sometimes see as a sprinkle in of our diagnoses specific to autism that come in. So picky eaters versus problem feeders. When do we need to raise red flags that we should be concerned? And this goes for our children with autism and for our children who don't have autism. So this can be just a really wonderful tool for you all to use in your practices to help identify which kids are needing more intervention and which are okay with kind of staying the course and working on outgrowing it. So picky eaters are going to typically eat with their family, but are usually going to have different foods. Our problem feeders are eating different foods and often cannot come to the table or cannot eat with the family. They're eating at a completely separate time. Our picky eaters are going to have a decreased range and variety, so greater than 30 foods typically. And then our problem feeders are 20 foods or less most often. Picky eaters, foods lost due to burnout, are going to return within 2 weeks. So think of it, if I have pretzels for snack every day for 2 weeks in a row, even though I love pretzels, I'm probably going to get tired of pretzels for snack. So I'm going to swap it out, but I'm still going to add the pretzels back in a little bit later after a break. For our problem feeders, once that food is gone, we've burnt down on pretzels, it's not coming back. Or if it does come back, it's going to be months to years later. Picky eaters are going to accept new foods on the plate. They might be able to smell, touch, engage with it a little bit. For our problem feeders, there's typically a meltdown, a really strong protest. Their tantruming is often what parents will describe this as with any presentation of a new food. They just cannot cope with even seeing that new food on their plate. For picky eaters, we're looking at consuming typically one food from all food groups, little bit of different textures. And then for our problem feeders, refusing entire food groups or refusing entire textures. I'll often see that we are going to lean towards foods that are predictable. So our snack foods or junk foods, the reason why those are typically preferred is because they're consistent. Every time you get a goldfish, no matter where it comes from, no matter who opened it, it's going to be tasting like a goldfish every time. A blueberry might be sour one time, might be sweet the next time. So it's not uncommon for us to see more of those carbohydrates, those more consistent, predictable foods as our main source of nutrition. For picky eaters, new foods are going to be added after maybe a few exposures. Maybe we present broccoli for a couple weeks in a row and now it's added. For problem feeders, if a new food is ever accepted, it's going to take 25 or more exposures. And so exposures can count as just seeing the food. It doesn't necessarily have to be tasting the food. It can be any range of engaging. And even with that, it can take a really long time for that food to be added. And then lastly, for picky eaters, parents might report it as sometimes as a concern that maybe sometimes meals are stressful, kind of goes back and forth on the week. For problem feeders, it is consistently reported at all of your well child checks that this is an area of stress and an area of high concern for families. So that kind of walks through those. And so what this might look like, I've had some people who prefer to do a checklist and have parents kind of fill it out on that last form. Which side do you think your kid falls in more? Some are going to ask more question-based, more interview, kind of more relaxed. And so these are just some ideas of how we can maybe get at some of that information without it feeling so standardized and leaving a little bit more room for that gray to happen. Because it's not always that black and white answering, and parents can sometimes have a hard time really categorizing it into one versus the other. So this can be just a great way to start to ask some of those questions to learn a little bit more about feeding patterns. So what makes a child with autism nutritionally vulnerable? There are a lot of patterns that children with autism have just as part of their neurodivergence that can then turn into impacting feeding, and explains why we're seeing such a high prevalence of feeding difficulties in our autism population. regulation. So one of those, we're going to see early onset of selective eating patterns or picky eater. This kind of ties into that restrictive and repetitive behaviors or interest. So kids like to know what to expect each time. So a lot of times I will see early onset where it's our kids, our infants who are gagging with even the slightest change to texture, the slightest chunk in their food, and they're having a really, really big response. We can't transition off the bottle. If we do milk in a different bottle or milk in a sippy cup, we lose our mind because it's not what's predicted. This is where we can also see our kids who, I've had ones that my goldfish can only go in the blue bowl. If you put my goldfish in that red bowl, absolutely not. I cannot eat it. And so these repetitive patterns that we're seeing then turn into our food, which makes their access to food a lot more limited. And we start to see some of that selectivity coming. We also will see use of elimination diets for addressing behaviors, speech, GI symptoms. Sometimes these are doctor recommended, sometimes it's social media recommended. Parents are just trying different things. But when we start to eliminate with gluten-free, casein-free, red dye-free, now we take an already potentially limited item or limited list of accepted foods, and we've restricted it even more because we're doing our best to try to manage other behaviors and difficulties. Then we also have increased occurrences of GI issues. Constipation is one I commonly see. Is it the chicken or the egg? Is it maybe that we've had constipation to start? Is it the diet that's impacting constipation? But when we have these increased occurrences of GI issues, if our tummy is full of stool, we're not going to have that hunger drive. And so often we'll see that that can impact too. Poorly regulated bowel movements is then going to impact our desire to eat and feed. Some more patterns that we'll see: sensory processing is often atypical. So how they're taking in touch, taste, sounds, and then also how they're understanding and interpreting their own cues. I've had some kids with autism who have been able to verbally explain to me, I don't know that I'm hungry. I have to hear my belly in order to know I'm hungry. So they're not making that internal connection to what's happening. And then touching, tasting, sound, all of those are going to be processed differently by these children with autism. And so we have to make sure that we're working on supporting that system because it can affect how they're interpreting food. I always like to bring attention, like, this is valid and their experiences are valid. We might think that this touch is normal or it's something that they should be comfortable with, but it's our job to either troubleshoot and figure out how we can work through that sensory experience or find a way to work around that sensory experience so that we can get it to our mouth. Social reciprocity is another one that can be challenging. So we often see that meal times are a very social experience for us as adults, and we have a lot of conversation. We talk with our families. We ask about our children's day. And if that part is hard and social interaction is hard, then it also makes it harder to come to the table to do a hard thing, which is eating for them, and then to have a new skill of social interaction. So we're adding a lot of challenges that are then going to lead to eating by ourselves, eating in separate rooms, things like that. And then lastly, we have delays in language development. This one can impact feeding in that kids can't articulate, they can't explain what it is that's creating these challenges with feeding. So it's hard for them to sometimes also follow instructions. If we don't have good joint attention skills where we're sharing and attending to maybe what the feeding therapist is modeling for chewing, then it makes it hard to learn that skill. And so that delay in how we're understanding language and also in what we're expressing can impact feeding. So how do we as feeding therapists help families navigate some of these feeding difficulties? This is where, again, there's a lot of nuances. So I tried to chunk it into our highlight points of where we might begin with feeding therapy. So we have first, we're going to establish routines. Then we're going to work on building the skills. We're going to reduce stress for the child, and we're going to reduce stress for the family. So for establishing a routine, some families are really good and they've already got some good routines in place, and some we are starting from scratch. But again, kids like predictability, especially our children with autism. And so if we can start to break down and have these predictable meal times, that's going to help. A lot of my kids on the spectrum are grazing. They're snacking. They're having a handful of goldfish at 9, and then at 9:45, they're having an apple slice, and then another hour later. And so what we're doing by having this grazing pattern is we're not allowing them to truly have experiences of hunger. They're eating just enough to get by. And overall, we've seen that when we're in this grazing pattern, the overall nutritional intake of food is going to be lower than when we have these set times. I always like to tell families this is a process. You are not going to go from a grazing schedule to immediately a sit down structured schedule. That's not going to work for the child, and it's not going to work for the family, and they're going to abandon the task. They're going to say, this is not for us. We're all done. And so working on finding consistency, where can we add? Is it we're going to work on breakfast and snack, and that's our first target. Sometimes this might be if a kid's mostly taking liquid nutrition. We might be starting with setting the schedule for liquids. Maybe it's Pediasure. Or we're going to be starting with their preferred foods. We're not even going to get to new foods yet. We're just going to work on preferred foods and building that routine. Next, we have to think about building the skills. So this is where sensory and oral motor skills and regulation, they all go together. I often think about self-regulation. A child can't engage in a challenging task if their basic needs are not being met. So if we're having an overwhelmed sensory system, we're not going to be able to then move on to a challenging task that is eating. So often I'll have kids engage in working with their occupational therapist. What is a regulating activity for them? Do they enjoy swinging? Can we do a little bit of vestibular input before we get them? Do we need to do some heavy work and push around a laundry basket filled with weights? So trying to get them regulated before we then work on feeding. Then we have sensory processing. So again, a child can't progress to tasting a new food if their sensory system is unable to first process it. I have some kids where, yeah, we're going to do the messy play. We're going to dig in. We're going to touch. We're going to smell. And I have some kids that touch is such an aversive experience and terrible negative experience for them that I'm going to use utensils. I'm going to skip it. That's fine. If we can work on other things to help them move through that sensory experience, then we can do that. And so that's where that individual piece comes in for that sensory processing and meeting their needs. And then we have oral motor skills. So a lot of times I will see families are like, I want them to eat carrots. I really want them to eat a meat. If this child has only ever had soft breads, I can't expect them to be able to chew a carrot. So if I give them a food that's going to be more challenging than the skill they have, they're not going to be successful. And so my job then is to help support that gradual progression of their feeding skills from a motor standpoint and a feeding skill standpoint to then support that transition. This also goes for kids who are 5 and still on the bottle for Pediasure, whole milk, whatever it is they're drinking as their main source of nutrition. Parents will often come in and be like, they're 5, they need to be off the bottle. I'm like, well, you're right. That's not an age appropriate for a 5-year-old, but this is how your child gets their nutrition. And they don't have the skill to eat more than 3 crackers at a time. So we're not touching the bottle until we've built the skill. Next, we're going to talk about reducing the stress for the child. So this involves a lot of taking the pressure away from the experience of eating. Presenting small portions can be helpful, avoiding power struggles. So a lot of times the parents will, first you do this, then you get to do this, eat this bite of broccoli, and then you get to have your TV show. When we're doing this bargaining, A, we're adding more pressure, and B, the child is only learning, I'm going to eat this piece of broccoli just to get through this moment, but I'm not actually going to want to like this broccoli. I'm doing it to get it over with. And so we're not doing anything that's actually long-term going to be helpful for these kids. We want to engage in regulating activities. So like we talked about earlier, involving the child in tasks that don't require eating, cooking. Maybe we get a baking sheet and put some Cool Whip outside and we're not even in the kitchen. If they taste it, great. We did an exposure, but there's not that expectation. We also want to ensure that they have good seating arrangements. So we want to make sure that we have good positioning. If they're able to sit at the table in a chair, getting them with good foot support, good back support. Offering preferred foods alongside novel foods. So often we'll see that if we can get kids engaged in the act of eating, it's then going to help them with exploring a new food. providing reassurance that they'll have access to your preferred food. Some of our kids are going to dig their feet in and dig in until they know that they're going to get their goldfish. So if we just tell them, yeah, you can have your goldfish, that's okay. And we're just exploring this other food right now. And then encouraging any type of engagement with a novel food, whether that's touch, smell, taste, whatever it is, we count that as a win. Reducing stress for the family. Again, this is often, I have some of my sessions where we don't even get the food out and we are just counseling the families and working on managing the family stress and the family pressures around feeding a child that has difficulties with eating. So I like to set realistic expectations. Progress is going to be slow and it's not going to be linear. We're going to make a big leap or maybe a small leap, and then it's going to tank and you're going to be like, they got sick and we lost every skill. And so really focusing on those small wins and letting parents know this is a marathon. Feeding really, really is a marathon and it's not a sprint. And so the more committed we can be to setting routines and staying on task and celebrating those wins, the more successful our families are going to feel in feeding their children. And the more successful kids are going to feel too. So that goes into that, encouraging families during their times of stress. So when the kid's sick, if it's a hard moment, keeping those routines no matter what. Then we also like to talk about using a reverse model for therapy. Our kids with autism are often recommended to be in therapy by a lot of places for years. I mean, we're talking decades. I've had some kids that are in nonstop therapy. I couldn't imagine being expected to go to therapy nonstop every single week for a decade. And that's just one therapy. A lot of our kids are in multiple therapies. And so we want to really support a burst model. And that looks like we build skill for 6 months. We've got in a good place. The family knows the home exercise program. Go home and practice it. And while you practice that, maybe you're going to do physical therapy. And then in a couple of months, when you're ready to get the next steps, great, we're going to come back to feeding therapy. And hopefully at that time, you'll be ready to fade out from physical therapy and go on a break, because our families get exhausted. Caregiver burnout is a very, very real thing. And so we want to help support what that can look like and take that pressure off if they have to be in every single therapy at all times, or they're not doing good enough for their child. And so really supporting that. And then keeping meals positive. Feeding is a skill that starts in infancy and is fostered throughout a child's life. So we want to keep it positive for both the child and for the family and reduce as much stress as we can. Referrals. We love our colleagues so much. We love all of you. You are wonderful and you help these kids in more ways than we can count. So for varying reasons, we're going to have our gastroenterologists, our ENTs, allergists, endocrinologists, dietitians. We need to make sure we're addressing medical in order to make progress with therapies. Our psychologists and our therapists, mental health counselors, they are all going to be wonderful advocates too. And also helpful, like I said, especially for our ARFID population, for those experiencing higher anxiety. Managing even generalized anxiety helps us then be able to focus and fine tune into feeding specific anxieties. You're a therapist, but yes, we love all of our colleagues, and all of us go into that team to make these kids have a more successful feeding journey. Referrals. I just wanted to touch base quickly. I know some of you are within the St. Luke system. We get referrals from both within and outside of. Unfortunately, I hate this. Every time I go to triage our kids, I do part of our triage poll for outpatient. We have such a high volume of referrals right now that St. Luke's is really only able to support a medical model. So our kids with autism who are 5, who have good weight gain, who have a fairly stable nutrition plan, as you can see, are going to be triaged as either normal or low priority. We're working really hard. This is one of my projects that in time, with more time and less patient care, if that ever happens, we'll do some program development to try to help these kids in the interim, because we believe in early intervention and know the importance of it. But resources, we are sometimes limited by those. So I had called last year a bunch of the clinics in the Valley to try to figure out where can we send these kids, if not us, then who. So this is not a comprehensive list. There's some in Boise, Meridian, and then the next slide has a few others. I think since then, there's been a few other clinics added, but these are all places that you can refer to as well. I can't personally vet any of their therapists there. I tried to speak at each clinic with an actual feeding therapist so that I can learn a little bit more of their background when creating this. But even at these community clinics, I know there's some fairly significant weight loss. The wait list. The Treasure Valley is growing at a fast rate. You guys are all, I'm sure, feeling that as well, that there's just not enough of us to serve everyone who needs to be served as timely as we all wish we could. But you could always refer to both clinics, refer to St. Luke's and refer to a community, and whoever they get in with first. I don't think that hurts to do multiple referrals. Here are just some wonderful resources on autism, on feeding, different ways that you can help support and guide your families. Citations for those, and then questions. I know we kind of flew through this, and I also want to make sure that you all know you are welcome to email me if you want breakout topics, if your offices would like to learn more. I have a general picky eating versus problem feeding presentation that I'd be happy to share too. Great, you offer at Northwest Behavioral Health too. I'm gonna add that one.
Well, thanks for that addition, Jamie. Courtney, let's open up to any questions. Amy?
Yeah, Courtney, I always waffle back and forth as to when to refer to medical nutrition therapy or a registered dietitian. At what point, right? And as an SLP and you're doing feeding therapy, do you like to collaborate with a dietitian? Yeah, tell us a little bit about that.
Yeah, so collaborating with our dietitians can be really helpful. I think we both learn from each other too. It depends on the kid's skill, and that's what's challenging, but it's always helpful if, are there ways that we can boost the caloric density of the skills? They also are really helpful in helping us determine, let's say a kid is on Pediasure and we're starting to get a little bit more oral intake. They can really help us set those guidelines of, can we go from 4 cartons a day to 3? Because we're not allowed to make those medical changes. And so having that dietitian involved can be really helpful, even if it's to be a contact point where maybe they're not followed every 6 months by a dietitian. Maybe it's a yearly, kind of depending on the kid. But it's helpful for us to have those parameters coming from them so that we can then help tweak on those week-to-week basis how we can cut back on supplements and then boost those calories too, where we can.
Thank you. That's really helpful.
Any other questions? You can unmute or you can put those in the chat as well.
Well, I have one more. As far as like intensive feeding programs, I know Idaho does not have any. So, what are your recommendations for families, if they're willing to go out of state to pursue, like I said, like a more intensive, maybe inpatient feeding program?
Yeah. So I've had some families who have come back from Portland. I've heard really mixed reviews. I think it depends. Most of our families, I think CHOP has a program. Children's Hospital California, I believe, has a program as well. I've not had a ton personally who have gone. I would say those who do go are typically going to be my kids with ARFID. And it's mixed review. From what I've got feedback wise from parents is they're really good at building in the short term, getting them eating, getting them to not need a feeding tube, but that long-term carryover isn't always there. And it's not, I think it varies on program on how much they're actually training and teaching families to support the skills once they're home. I would say for like my ARFID kids, a lot of our kids who have that diagnosis, I'm trying to do that more intensive where we're starting maybe 2 times a week, if not weekly, to at least get started and get a really great home exercise program established. So we sometimes have that flexibility depending on the kid to do a mini intensive here, more or less.
Courtney, thank you so much. Kate, did you have a question?
I did.
Okay, let's go to your question and then we'll transition to our case and wrap that up.
Sorry, just
Thank you.
Sometimes I struggle with the kids that are not eating throughout the day. They won't eat dinner and then, they fall asleep and then they're up in the middle of the night, rummaging through the pantry. Yeah.
Yeah. How to troubleshoot that? Is that the question?
Yeah, without creating this like guilt and shame,
Yeah, I
food
think
relationship.
that's where working with families to identify a schedule if you can. Like, what works best for your family? Can we at least get breakfast in there? I would say dinner traditionally is going to be the hardest meal. Kids even not on the spectrum are falling apart at dinner time because they've been asked to listen all day at school. They're burnt out, they're tired. Parents have worked all day, we're burnt out, we're tired. So I would say, even if you're starting just on the weekends, when parents have the full day, especially for our kids who are school aged, or focusing on breakfast, can we wake up 10 minutes earlier and at least get kids to come to the table? Sometimes that's where I'll start too. Can we do 10 minutes at the table, even if it's preferred snack or we don't even have the snack directly in front of us? Maybe it's off to the side, but we get to do a coloring activity. We can use some of those other motivators, and just even starting with coming to the table, and then we can start to build in those snacks. Does that help? Okay.
Great. Cortney, thank you so much. I know you have to run. If there are any outstanding questions, please reach out to Echo. We'll get those to Cortney and get some questions answered. We appreciate you greatly. Thank you.
Thank you all so much.
Okay, we're going to transition to our patient case today, and we're really happy to have your case here. So Anne, can you introduce yourself? Let us know where you're at. I'm going to pull up the case for folks to follow along. And also, while Anne is presenting, I encourage you to be thinking of those clarifying questions that you have for her, and then we'll move to recommendations.